Our next speaker awoke with a sore throat yesterday, and it's 2022. So she is online, and we're grateful to her for that. And so we're gonna view her talk virtually, and she will be available to answer questions live. She is Dr. Prashanthi Vemuri, who is a professor of radiology at the Mayo Clinic in Rochester, Minnesota. Dr. Vemuri is world-renowned for her studies of brain imaging in particular. She has more than 200 peer-reviewed articles. She was awarded the 2020 Mani de Leon Prize in Neuroimaging, and one of her recent NIH grants includes the title Exceptional Aging, and she is going to present a lecture on resistance and resilience. Take it away.
Good afternoon, everyone. It's my pleasure to be here and to be able to present it via Zoom. And I'd like to thank the organizers for facilitating me presenting the work at this conference. I'm going to talk about factors that contribute to resistance and resilience in the aging population. And before I begin, I'd like to give you a little bit of a background of where I'm from and what I study. I'm one of the imaging investigators in Mayo Clinic study of aging. It's a population-based sample where individuals from Olmsted County, Minnesota, which is in the southeast part of Minnesota, are invited to participate in our study, and they undergo imaging, as well as we get a wealth of longitudinal data on individuals to try and understand how people age. Currently, we have about 3,200 active participants across the ages of 30 to 89 years of age, and we have a significant amount of follow-up, especially in individuals who are 70 years or older. What we generally see is that we see a lot of heterogeneity in the aging population. We see, as shown by the red circle, individuals who are 80 years of age and do not have any brain changes. At the bottom purple circle, we see individuals who are 70 years of age and substantial brain changes with high risk of dementia in the next 5 to 10 years. And then we also see individuals who are cognitively intact, but have a lot of brain changes. They're able to cope with all those changes. And we have observed, as well as individuals across the globe, scientists who are studying the heterogeneity in dementia risk, that several factors contribute to the risk of Alzheimer's disease. So one of the goals of my lab has been to understand what factors cause the heterogeneity in the brain aging. I'm an imaging scientist, so we look at PET images and MRI images, connectivity changes in the brain, how the brain's vessels are aging, and so on, and try to bring in factors throughout the lifespan of individuals, how they sleep, what did they do for their job, how much exercise did they do during their midlife, and so on, and try and understand how different factors may contribute to the heterogeneity that we see with brain aging. And just an overview of my talk, I'm going to talk about two mechanisms and trying to link the factors we find to these two mechanisms to try and explain my work. The two mechanisms are resistance, how do some individuals avoid pathologies, brain pathologies, and resilience, how do individuals cope with different pathologies. There are some individuals who have significant amount of brain changes, but still able to function normally. How are they able to do that? And these two mechanisms are two discrete ways in which people avoid dementia. So let's begin with resistance, or how do people avoid pathologies. And before we understand resistance refers to trying to avoid pathologies. I need to give you a little bit of background of how do you measure pathologies. In the last 10 to 15 years or so, there are more methods available to measure the degree of pathology in the brain. For the two pathologies that underlie Alzheimer's disease are amyloid beta and tau. These two changes happen in the brain, and these can now be measured using PET imaging, CSF by getting a lumbar puncture, or the recent methods also use just plasma to measure the degree of amyloid and tau in the brain. that's reflective of how much Alzheimer's disease pathologies you have. So if you have a normal, cognitively unimpaired individual, your tau and amyloid PET scans, which indicate the amount of pathologies, look like the images shown on the left here. But if you have Alzheimer's disease and you have clinical symptoms, you have the brain light up like a Christmas tree, showing that you have significant amount of tau pathologies and amyloid pathologies, which are reflective of Alzheimer's disease. The people that we call exceptional agers in our study, as well as trying to understand how resistance works, we focus on the last column here. These are individuals who are 85 years or older and do not have any amyloid and tau whatsoever, really beautiful looking brains. And they have no very low burden of amyloid and tau, reflecting that they're able to resist the pathologies that increase with age. Just to understand how many people really have amyloid-related changes in the community, this data is from our study, which was published a few years ago, and you can see that between the ages of 50 to 54, not a lot of people have much amyloid, about 2.6% of individuals. But by the time you're 80 to 84 years of age, the prevalence of amyloid positivity of a scan looking like a Christmas tree on an amyloid PET scan is about 60%, which is extremely high. And to note that there's some people who do avoid getting any changes in the brain, and we really want to understand who are those people. One well-known risk factor, as we know, is age, right? If you're younger, you're at less likelihood. But also there is a gene called ApoE4, and the presence of ApoE4 allele. There are two alleles. If you have two alleles, you're at higher risk of getting amyloid. So you get it much earlier in life, shown by the first curve here. If you do not have two copies of the allele, then your likelihood of getting amyloid is much lower. So you don't get much, even though you go from 60 to 100 years of age. And what factors contribute to amyloidosis? There are a lot of factors that are being studied, and one of the factors that we have studied, following a lot of focus on how poor sleep quality can actually be bad for clearance of toxic metabolites in the brain. Just like sleep is really good for everything. You need your beauty sleep. You also need to sleep well and have good quality of sleep in order to reduce your risk of cognitive decline, because your brain during the sleep is able to clear the brain of toxic materials. And then what we find is that work done in our lab is that indeed, if you try to follow individuals over time, so in this particular study, there were about 250 individuals who were followed over about 2 years of time, and we tried to see how sleep impacts the amount of amyloid they have in the brain. And we do find a strong association between how the quality of sleep is compared to the amount of amyloid an individual has. I talked about two pathologies. One is amyloid, the other one was tau. If you have amyloid, it increases the risk of tau deposition. So if you have amyloid, if you do not have amyloid and you're older, you're represented by the blue diamonds here. But if you're amyloid positive, you have significant deposits of amyloid, your tau also goes up. It's a domino effect. If there's significant amount of amyloid, that's very, very, very causal to driving a lot of tau deposition in the future. And we found that several factors contribute to more tau. You could have people who are amyloid positive, but have low tau if they have better stress coping abilities. They're able to cope with stress better, and they have less number of witness apnea. Sleep apnea is a risk factor for greater tau deposition. And we also find that genetics plays a role in who has more tau versus not at the same level of amyloid. But one thing with tau we have been struggling with is that the amount of effect is small. So on the left-hand side is some work done on witnessed apneas in individuals. And we find that if blue circles are individuals who have amyloid but do not have apneas, and red circles are the ones who have witnessed apneas. And you can see that people with witnessed apneas have more tau deposition than those who do not. And so when we're talking about resistance, one of the things that we have found is that age, of course, is a very important factor driving people having more pathologies, but genetics, sleep, stress, there's some indication physical activity may play a role, but it's not a very strong association. But in terms of genetics environment interaction, there might be a strong relationship between people who have low amyloid versus a lot of amyloid and tau based on multiple factors. The next part of the talk, I'll talk about resilience, where how some individuals cope with pathologies. And there are two kinds of mechanisms of how they cope with pathologies. One is brain reserve. Brain reserve just says that you start out with more money in the bank. So you can have less money in the bank, so if you have less to expend, or you could have more money in the bank, so you have more to spend as you age. And that refers to the concept of brain reserve, where some people have just more neurobiological capital. And we're trying to understand how is that possible, that some individuals have more neurobiological capital than others. Some work done by Brian Nath and our group tried to study individuals between 50 to 65 years of age, and we found that not everybody ages very similarly. There are some individuals who have higher midlife risk factors, which makes them vulnerable to more age-related cognitive disorders. They have higher reserve than others, and this changes in midlife quite a bit. And we studied a variety of midlife risk factors, physical activity, education, occupation, as well as general health factors of what is their BMI, what is their what are their glucose levels, how about their depression inventory score, and so on. And we found that generally, if they have better health overall, they have better brain health in midlife. So we studied the brain, we studied structure, we studied connectivity, and we studied how much amount of energy the brain is consuming. And we found that people generally have better health. So they have lower number of risk factors. So they don't have hypertension, they don't smoke, they don't generally do more cognitive activities and physical activities, then they have better brain health in midlife. We also found that in general, all the midlife factors are predictive of more loss of volume in the future. So does exposure to surgery, also increases the likelihood of increasing your risk of dementia. So all these factors add up one at a time to put individuals at increased risk of dementia. The second part of resilience comes from other pathways to cognitive impairment. When we talk about pathologies, here we're talking about Alzheimer's disease pathologies, but there are other pathologies that could also cause cognitive impairment and dementia, which include cerebrovascular disease, CAA, Lewy body disease, TDP-43, and people who have low pathologies or stronger pathways in other dimensions also contribute to having lower risk of cognitive impairment. Taking vascular disease as an example, some individuals could have amyloid, but they have no vascular changes. They have very strong vascular disease pathways. Or some individuals have both, in which case they decline really fast. So having low vascular disease related changes, even though if you have do not have amyloid, could be detrimental. So people who are able to cope with pathologies better are individuals who have changes due to other pathologies much less. And white matter connections are often studied very, very less in Alzheimer's disease. This is a Delta route map. So Delta Airlines has a hub in Minneapolis, and you can see that there are connections throughout United States. Similarly, white matter is the way the brain is connected, and it's often not studied very well in Alzheimer's disease. And we find that people actually age very differently. There are some individuals shown by the purple circle here. If you take their scan at 60 and follow them for a long period of time, their connections don't age as much. But cluster 4, shown at the bottom here, some people start out really well, but really get to the danger red zone where the connections are declining at a very fast rate compared to other individuals, and this puts them at higher risk of cognitive impairment. We have found that using better imaging models and figuring out what connections to measure, we can actually pinpoint to where the connectivity is impacted due to various pathologies and how that connectivity plays a role in cognitive impairment. So we've been trying to develop better imaging models to try and understand these. And what does this mean? Why are we studying these connectivities? We find that similar to what Accord Mind and Sprint Mind study showed, that they did intensive blood pressure control and they found that people have less number of lesions in the brain. We also find that people who have who work out in their midlife, they don't smoke less, and they do a lot of cognitive activities, are less likelihood of getting hypertension, and that is related to better white matter connectivity later in life, and that's indicative of lower risk of cognitive impairment. Genetics also plays an important pathway. Even if you have very similar amount of amyloid, unless you have high genetic risk or protective factors, there are some individuals who have this particular gene, which is related to synaptic plasticity, who don't decline as fast and are much more stable throughout their lifespan compared to individuals who do not have this gene, who are at higher risk of cognitive decline. Looking ahead, what should we look at and which direction is the field going into? We find that cognitive aging is a multifactorial process, and we are moving towards developing more generalizing learning models and methodologies that capture the complexity and heterogeneity of the disease process. And having each one of these and studying each one of these is very important to try and understand how do we reduce the risk of cognitive impairment. And in the future, we see the way the field is heading is that we measure your genes, we measure the risk and protective genes, your education occupational level, get your images, and we'll be able to tell you precisely the kind of cognitive trajectories you would be on if you are high or low for one of them. So blue is the best case scenario in our cohort, and red is not the best case scenario, which puts you at much higher risk of decline. And you can see that you could have completely different trajectories of aging if you have certain protective factors. In summary, I hope I got across to you that cognitive aging is a multifactorial process, and then there are two broad mechanisms that can aid in exceptional aging, which are resistance and resilience. There are some mechanisms that help you avoid pathologies, but there are some other mechanisms that help you with coping with pathologies, and both are important when you're moving towards exceptional aging. And I'd like to thank our study participants and families, the lab, our collaborators, as well as the grant support that makes all the work possible, and for your time. And exceptional aging is a lifelong endeavor, and multiple factors play a role in it. I'm happy to take any questions at the end of this talk or via email. Thank you.
Okay. Professor Vemuri, are you, can we unmute her so she can, hello.
Hi, so I apologize for not being there. I appreciate your accommodations.
No, it was a great talk. We hope you're feeling better. Thank you for doing this. And we're going to open the floor to questions. We got one over there.
So my question is related to the white matter and connectivity. And I was wondering if you were considering looking at, sex-related differences, because there's some good studies showing, difference in terms of like white matter localization, like for example, between females, it's more between the hemispheres themselves, and when males is within the hemispheres, but it also goes down to different areas of localization. So do you think that's a contributing factor in potentially why white matter might be offering resilience, but it also might be contributing to some of those sex-related differences we see?
That's a fantastic question. And we have been seeing a lot of differences between men and women in terms of white matter connectivity, especially the corpus callosum, we see that women start out with a little lower connectivity, like in terms of the integrity, it's slightly lower, which puts them at higher risk. We see that women get much higher hyperintensity over their lifespan compared to men. And some recent studies we have done have also looked at, in addition to cognitive impact, we've also looked at gait. And we find that women, because they start out at a lower amount of integrity, they're at much higher risk of falls and motor dysfunction. So yes, sex differences plays an important role.
Professor Vemuri, there's a question in the chat about whether people who have anxiety or depressive disorders as young adults, whether these factors contribute to their resistance or resilience or abilities therein.
So I don't think there's a direct relationship. The jury is still out there because these studies that have been done so far have shown that early amyloid and tau deposition are related to depression and anxiety. So we don't know if they're causal. I think it's a chicken and egg problem. You see amyloid, likely it's associated with depressive symptoms, but I don't think there's a clear-cut relationship between those disorders that you've talked about and Alzheimer's disease.
And not directly related, perhaps, but you showed a bit of data from a paper I enjoyed about coping mechanisms with stress and the likelihood of tau pathology in people who have amyloid.
Yeah, very related. Chronic stress, people who seem to be able to, it's the HPA axis, Dr. Grill, but I think the jury is still out there. It's a chicken and egg problem. We cannot say it's purely causal.
I think we have, excellent.
Is it on? Okay. Hi. My name is Debbie. I enjoyed your presentation very much. And I just have kind of a simple question. You were kind of glazing over certain things that would help our health and, to maybe ward off Alzheimer's or dementia. You mentioned sleep. What, in your opinion, or what are the statistics on how many hours we should get?
So there was a large study that was published in Neuroimaging, which showed that 7 hours is a sweet spot, but there was significant heterogeneity. I think some people need more and some people need less. I wish I needed less, but 7 seemed to be the sweet spot.
Any other? I'm seeing pointing. It's very bright. Oh, great.
Thank you. Hi. So I was wondering, you mentioned that amyloid that you can still have brain resilience, but I was wondering, can you still have resilience if you are already showing cortical thinning?
No, it's a little bit more harder if you have a brain thinning. So you could have resilience after you have amyloid. There's more possibility, like 30% of people with amyloid and about 50% of people at the age of 85 or older, if they have amyloid, they don't have tau changes in cortical thinning. And if that's common. Once you have tau, you most likely see, once you see some amount of tau, you see decline in memory. But once you see neurodegenerative changes, cognitive changes occur almost parallelly. So that's a less common scenario.
Yes, hi there. Enjoyed your presentation. I'm Mark Wilson. Hey, just a question about, you mentioned surgical exposure is a factor that influences. Is it the anesthesia? Is it the trauma of the surgery or the time to recover? What's you're learning about that? So
the research out there right now shows that more exposure, number of surgeries you have had, is neurotoxic to the brain. It's not specifically increasing amyloid or so on, but it is contributing to the overall brain reserve that you have. Just like we talked about factors like hypertension, smoking, multiple surgeries add up and the impact is neurotoxic, and it's associated with cortical thinning. It has nothing to do with amyloid or tau, but it's associated with slight amount of cortical thinning. one thing to remember is that all the factors we talked about are small bits of information. It's not like yes and no, like you have hypertension, so it's really detrimental. But it seems like all the factors add up little by little. Even though the effect is small, they all add up, and the overall effect is very significant. It's not like you have a surgery that's very detrimental, but all the surgery taken in the context of other things that are going on with your health is bad. Hopefully that helps answer the question.
Dr. Vemuri, there were two follow-up questions for you about sleep in the chat. One is whether the type of sleep matters, that is, people who require sleep aids or sleep medications, and also what's the best time to start those hours of sleep?
So if you guys have an Apple Watch, deep sleep is always good, right? If you measure the amount of deep sleep you have and you monitor what impacts that, that's important. But I'm not a sleep medicine doctor, so I cannot directly relate to what is the best time of sleep, time to start your sleep. But tracking it would be useful when you get the best deep sleep.
Great, excellent. See one more in the audience here.
Hi, yeah, thank you so much for your talk. It's so helpful. I've read recently that alpha-lipoic acid might help in the membrane that goes around the brain to conserve that so that it doesn't become perforated. And then my second question is it possible to catch up on sleep?
Tough questions there. Tough questions. I don't think I have answers to them. Dr. Grill, you can chime in if you have ideas or answers to those questions.
Sure, I'll give it a shot. I've not seen anything about alpha-lipoic acid, certainly in the realm of evidence-based approaches to looking at that. And I'm going to refer you to the UCI Mind website because we've got a lot of real sleep experts around who we're going to have to invite next year, given the level of interest in the topic. I have seen some suggestions on catching up on sleep, but not as it relates to Alzheimer's disease. All right, Dr. Vemuri, thank you so much for doing this. Fantastic talk.